are live on YouTube now.
Okay. Good evening, friends. I welcome you all on behalf of SRCC Children's Hospital, managed by Narayan Health, located at Haji Ali, Mumbai. I am Dr. Rasik Shah, Senior Pediatric Surgeon, and today's topic is antenatal diagnosis of spina bifida hydrocephalus and management of that. As all of you know that we have at SRCC hospital, we have a large hospital with a lot of social distancing, uh, and we have all the specialists under one roof, which includes pediatric neurosurgeon, pediatric cardiac surgeon, oncologist, pulmonologist, and under one roof. uh, all subspecialties. We have state of art, all departments which we want under one roof. And today's program or this particular panel discussion, we have galaxy of panelists, starting from senior Dr. Chandar Lula, who has huge experience of antenatal sonography. He has published many papers and he has been president counselor of all societies related to fetal medicine. Our next panelist is next slide, please.
Yes.
Yeah. So Dr. No, take go back. Yeah, Chandralulai. Then we have Dr. Nakul Kothari. Nakul Kothari. He's a neonatologist who was trained at MGM New Bombay, and then he did fellowship in neonatology at Sion and then Westmead Hospital at Sydney. And now he's with SRCC Children's Hospital as a full-time consultant in critical care and emergency services. Our next panelist is Dr. Naresh Biani, who did MBBS from Mysore, MS and MCH from Mumbai University, and then he did fellowship in pediatric neurosurgery from Tel Aviv Medical Center, from GOS Hospital, London, and San Francisco, USA, and he's practicing in Mumbai since 2008, and he's with us at SRCC Children's Hospital. Our next panelist is Dr. Sumit Pawar. He's also pediatric neurosurgeon with a lot of experience in endoscopic spine surgery, and he has done fellowship in minimally invasive spine surgery from Japan and Taiwan. He is a editor-in-chief of Journal of Spine Surgery, and he has written a lot of articles, book chapters. Our next panelist is Dr. Pooja Wazirani. She has done MD in OBGYN and then fellowship in medicine from Chennai, and she is practicing in Mumbai at multiple places and also at SRCC Children's Hospital, Hajri. Next slide, please. Dr. Rajini Krishnan is alumnus of BJ Medical College, and she was first in MBBS as well as MD radio diagnosis, and she has been practicing for last 15 years at Visakhapatnam, New Delhi, and now at Mumbai. And she is full-time consultant in radiology department at SRCC Children's Hospital. Dr. Shilpa Agarwal, she did again OBGYN and then fellowship in high-risk pregnancy and fetal medicine from well-known institute, Fernandez Hospital, Hyderabad, and then fetal ultrasound training from Mediscan, Chennai, and genetic counseling from SGPGI. She is interested in high-risk pregnancies, and she is with us at Children's Hospital. Our next panelist is Dr. Shruti Bajaj. She did MD Pediatrics in fellowship in clinical genetics from KEM Hospital and additional training at Kasturba Medical College, Manipal, and Switzerland. And she is practicing in Bombay as well as at SRCC Children's Hospital. Next slide, please. So today's topic is by Dr. Shetal Mehta. She is going to be the moderator of today's session. And she has done MBBS from Sion And then from GS Medical College, she is OBGYN. And then 2 years she worked at Mediscan as a fellow in fetal medicine. And then from Canada, Sikh Hospital, Sikh Kids Hospital, Toronto, and Mount Sinai Hospital. And she is going to be the moderator for today's session. So over to Shetal for continuing the proceedings.
Thank you, sir. Am I audible? Am I audible?
Yes, yes.
Yes, yes,
Okay,
yes.
thank you.
You can go to slideshow and then continue.
So the aim of today's discussion is to discuss the ultrasound diagnosis, the antenatal and postnatal management of disorders of dorsal spine induction, or as we call them, the neural tube defects. To begin with embryology, the process of forming of the neural tube begins very much early in pregnancy when the initial bilaminar embryo becomes a trilaminar embryo by a process known as gastrulation. So basically, if you see on the left, original embryo has two layers, the epiblastic and the hypoblastic layer. This epiblastic layer is the one which eventually forms the three layers of the embryo, the endoderm, mesoderm, and ectoderm, whereas this hypoblastic layer forms the extraembryonic cells. So when by a process of gastrulation, this epiblastic embryo eventually differentiates into three layers, where a specific area called primitive streak is formed, which is how the embryo gets divided into craniocaudal left-right direction. From this primitive streak, epiblastic cells venture inside, go deep, and form a specialized area called notochord. It is this notochord which induces the development of the neural tube defect by acting on the layer above it. This notochord is formed at the third week of gestation. So what happens is this notochord induces the epidermal cells on top, which initially form a groove or they fold inside a little bit, and then these folds become acute, and then eventually they completely pinch off from the surrounding cells. So these cells, which eventually pinch off from the upper cells, are what forms the neural tube. And this process is called as the neural tube formation of the neural tube, which starts around day 22 to day 26. This procedure of forming of the complete tube is called primary neurulation, and this is what is involved in the formation of the thoracic, cervical, and the lumbar spinal cord. The lower lumbar and the sacral cord, along with the filum terminale, is a separate process called secondary neurulation, which occurs much later. The upper end or the rostral end of the neural tube closes by day 24. If that stays open, it gives rise to anencephaly. The caudal end closes by day 26. Any defect in closure of the caudal end would give rise to open neural tube defects or spina bifida. Usually the closed neural tube defects occur because of the problems in the secondary neurulation, then usually occur lower down in the cord. So moving on to basic anatomy, how would you visualize the spine at anomaly scan at 18 to 20 weeks, Dr. Rajni?
Basically, one has to start evaluating the spine from the top to the bottom. See it in three planes. The one that is shown here are the sagittal and the parasagittal images. You have to see it in the axial planes, you have to see it in the sagittal, and you have to see in the corona. In the axial, you should be seeing three ossification centers. One which is more anterior is to the body side is of the vertebral body, and the two which are posterior should be meeting together, forming a V pattern. See that they are not splayed as you sweep from the head to the bottom. Then you turn the probe perpendicularly and see it in the sagittal plane, in the mid-sagittal plane, and in the parasagittal planes. And also see it in the coronal plane. You should see parallel lines with one line in the middle. This is because usually the interpedicular distance is maintained. Remember that at the cranial end and at the sacral end, there will be a little bit of widening, but still the posterior elements should be meeting with each other.
Thank you. Moving on. Dr. Pooja, this is visualization of the vertebra. How would you visualize the spinal cord in particular?
So the ISA guidelines say properly that the spinal cord needs to be visualized in the longitudinal section. You will see it as a hypoechoic area with an echogenic margin. The lower margin, however, cannot be seen in the longitudinal view. The central echogenic area is the central canal of medulla. The tip of the conus should be facing the vertebral bodies anteriorly, and you should have some amount of fluid in the neural area, the neural groove. And the tip of the conus again has to be labeled at which level it has to be seen. So that completes the important assessment of the spinal cord. Now, due to the relative position of the spinal cord as for the growth of the vertebral body, there is a relative ascent. So the tip of the conus at the mid trimester should be at the level of L3 or even more, not below that. And anything deviation from that will give rise to or raise your antennas for spinal dysraphism. So these are the important structures. Identify the conus, the spinal cord, level of that as per counting the vertebral bodies accordingly. And you can use a high frequency probe for better visualization if the patient is obese or any other important structures.
Thank you. Dr. Lulla, some expert tips which we could get from you in order to visualize the spine in certain cases?
Yeah, see, fortunately, at the second trimester anomaly scan, the spine can be easily visualized because the fetus is moving around. But if the spine is facing anteriorly, it's always better to see the spine, and especially if it's a vertex presentation, you can see the caudal end very well. We usually face problems when we are having a breech presentation, and there we would like to use a transvaginal transducer or even a high frequency linear transducer. We are all using 911 megahertz, and you can see the beautiful picture that you get. And then you lighten your pressure on the probe. This is very, very important for when the spine is anterior. Sometimes when your pressure is too much, your anterior wall of the uterus or placenta may compress and reduce the fluid content between the spine and the uterus, and you may miss small meningoceles. Here you see a small cord, I think there, loop of cord, which should not be mistaken for a meningocele. So these are the basic things, and you can sometimes even turn the fetus. If the fetus is not in a good position, you can turn the fetus and rotate it and try. Of course, 3D ultrasound is very good to see the site of defect and the level of the defect. But basically, we all see in 2D imaging most of the abnormalities, and 3D gives us a good coronal view and also gives us good spatial orientation of the lesion with the respect to the 12th rib and the iliac crest.
Thank you, sir. So let's begin with the first case. She's Mrs. SK. She's 23-year-old, gravida 2, abortion 1, with no other prior risk factors. Her first scan is at 19 weeks, 3 days. Dr. Rajni, could you help me with the findings, please?
These are actual sections that have been taken through the fetal cranium. The first one is at the transventricular level, where quite obviously one can see that there is ventriculomegaly at the posterior part, and the anterior part of the calvarium, that is the frontal part, shows these bifrontal depressed areas, which we call as the lemon sign. This should immediately prompt you to suspect that there is some spinal abnormality further down. At a slightly lower level, again, this is the fetal cranium itself. This is the transcerebellar plane, where the normal appearance of the cerebellum has been lost, and it is sitting like a banana along the posterior aspect of the relatively small appearing posterior fossa. And then further down, as I said, you should suspect that there is a spinal abnormality. The first one is an axial plane taken at the level of the kidneys. So that is the L1, L2, L3 level, where there is distinct splaying part of the posterior elements. The 3 dots that should normally be seen are not seen clearly, and there's a clear gap between the two with a U sign. Apart from that, one also sees that there is mild fetal pylectasis bilaterally. On the sagittal sections, you can see that there is this soft tissue that is noted with the non-visualization of the clear 3-line pattern that we normally see. So it suspects that there is an open neural tube defect that is wonderfully depicted on the 3D images. So this was a type 2 Arnold-Chiari with a lumbosacral meningomyelus.
Thank you. Dr. Pooja, can you explain the pathophysiology of the cranial findings that you see in an open neural tube defects, please?
In the open neural tube defects, you have the exposure of the neural elements to the amniotic fluid, and there is leakage of the cerebrospinal fluid. This causes a relative hypotension in the subarachnoid area, and that is the reason for the caudal or the herniation of brain structures into the foramen magnum. And because of that, there is a decreased pressure in the cranial intracranial area also, causing a scalloping of the frontal bones, and that leads to the lemon sign, which is seen, majority of them will be seen less than 24 weeks. And also the banana sign, which is seen in the head, is because of the herniation of the posterior fossa elements into the foramen magna. So basically, it's hypotension because of leak, and that leads to obliteration of the magnum, causing the further side effects are ventriculomegaly, hydrocephalus due to obstruction flow of the CSF.
Is the lemon sign specific for neural tube defect? If it's the only finding, should we suspect something else?
Lemon sign is not specific for a neural tube defect unless you associate that with the banana sign and you see the spine along with the open neural tube defect. In 1% to 2% of normal fetuses also you will have the lemon sign in the early gestation. Second, if your probe pressure is too high, then you can have a lemon sign. Sometimes in craniosynostosis also, you can have a lemon sign in terms of your which part of the sutures are closed, especially the coronal. So when you have a lemon sign with a normal posterior fossa, normal spine, okay, then you see the sutures, see the week of gestation, and then alarm yourself and the patient. Otherwise, it can be a normal finding also in presence of a normal good anatomical scan of the baby.
Right. And how would you determine the anatomical level of the defect in case of an open neural tube defect?
So there are two ways. You can go from down to up and from up to down. When you come from the T12 level, you need to, the last rib with the vertebra is usually at the T12. So you count down from there. And in the mid trimester, the faintly ossified area near the sacrum region is usually S4. So you count up from there. So you can use either of the techniques to identify where exactly is your level in the lumbosacral or below the thorax.
Thank you. Role of maternal serum alpha fetoprotein in today's times. So screening by MSAFP was originally done at 15 to 20 weeks, where a value of more than 2.5 multiples of median was associated with an increased risk of open neural tube defect. And this method had an 80 to 90% detection rate for neural tube defects. Dr. Shilpa, why would an MSAFP be raised in open neural tube defect?
Yeah, so MSAFP is basically maternal serum alpha fetoprotein, and alpha fetoprotein is a glycoprotein which is produced by fetal yolk sac, liver, and GIT. But the major portion is from fetal liver, and the level in the mother's serum increases from end of first trimester till 32 weeks. So this is how we know that this is the normal thing which happens with AFP. But now in open neural tube defect, the CSF is leaked into the amniotic fluid. So also from the fetal serum and from the CSF, this alpha fetoprotein is in the amniotic fluid. And so basically there are two causes for increase in maternal serum. One is transplacental and the other is transamniotic. So but the transamniotic portion is actually very less, but the major portion is by transplacental. So through fetal serum, it goes into the maternal serum and we get what is known as high AFP. Now, coming to the moms, so multiple of medians, so it is a request that we should not take this value as an absolute value. It should always be converted into mom before we interpret the results. So when we have MSAFP, which we do in second trimester, so more than 2.5 mom is taken as an increased risk. The specificity is very high, that is 100%. It is very specific, but the sensitivity is low in second trimester with a false positive rate of around 1 to 3%. So the false positive rate is 1 to 3% in second trimester. And that is the reason why we use AFP in second trimester and not in the first trimester. Because first trimester, the detection rate is only 50% and the false positive rate is 10%. So ideally, we are not gaining anything by using that marker in first trimester. And this is how we use it in second trimester.
Right. What are the other causes for raised maternal serum alpha fetoprotein in the mother's blood?
Yeah, so as we said in open neural tube defect, so wherever there is a discontinuation of fetal skin, we will have a raised AFP. So like in gastroschisis, or you have omphalocele, or fetal skin disorders, or nephrosis. So these are the, the first and foremost is wrong dates. I am extremely sorry, I should be saying that the first, because wrong dates is what we have to keep in mind whenever we are interpreting results of maternal serum alpha fetoprotein. So first, calculate the gestational age and then interpret the results. Yes, multiple pregnancy, we can get double the amount of maternal serum alpha fetoprotein. In intrauterine fetal death, the rate, there is a rise in MSAFP. And as I said, in other disorders like nephrosis and skin disorders.
So in case of a report which says there is high MSAFP, but if the anatomy scan is completely normal, is there any other thing that would concern you in such a pregnancy, or is the mother free?
This is a very important question, because this signifies the importance of pre-test counseling. So I think for any screening test, MSAFP is a screening test, and pre-test counseling is a must for any screening test. So a pre-test counseling where we tell them, okay, if this is high, these are the possibilities. We will do an anomaly scan, but even if the anomaly scan is normal with high AFP, there are chances that there can be abnormalities. So related to placental dysfunction. So she might be at high risk of preeclampsia, placenta accreta, percreta, premature rupture of membranes, fetal growth restriction. So these all placental dysfunction basically can happen when you have a high AFP with anomaly scan normal.
Thank you. Moving on. Dr. Lula, what is the association with spina bifida? What other associated anomalies should we look for if we see this finding?
Yeah, more than the associations, you have to see a lot of intracranial signs, both infratentorial and supratentorial. I think infratentorial, Pooja has already said the banana sign, but you must remember that when there is a leak in the spina bifida region, there is decreased in intracranial pressure, and we initially on a sagittal view see that something called the clivus occiput angle is very narrow. So there's like a funneling of the posterior cranial fossa. And this causes compression and herniation of the hindbrain upwards and downwards. And this upward herniation can cause stretching of the tectum. So you get tectal peaking, and you can get obstruction of the aqueduct, and that can cause ventriculomegaly. There are a lot of associations, intracranial associations, very, very important in the form of cortical developmental disorders, agenesis of corpus callosum or dysgenesis, polymicrogyria, heterotopia. Now, all these put together raises the issue sometimes that this could be a genetic predisposition or programming which leads to these kind of associations. Of course, you have a lot of other extra CNS abnormalities, syndromes, like the OEIS associations. We have the vectoral associations, and genetic associations, 13-18 Turner syndrome, and all these other cardiac pathologies and renal pathologies are very commonly associated. So we have to look at all the various organs to confirm whether this is an isolated neural tube defect or it's an associated malformation which has different outcomes. And also very important when you're counseling, because if it's an isolated defect, the prognosis can be a little better, whereas the prognosis is bad if there's anything associated. Also, the intracranial signs are very, very important, because each of them indicates that the outcome depends. So if there's mild ventriculomegaly, you may need a ventriculoperitoneal shunt. If there's tectal beaking, you can expect nystagmus, and because the third and fourth nerves go along the tectum, and you can expect nystagmus and other auditory problems. If there's polymicrogyria and periventricular nodular heterotopia or cortical disorders, you can expect epilepsy and IQ problems, and so also corpus callosum, which is very, very important, because then you can expect IQ. So all these issues associated can lead to prognostication of the pathology.
Right, thank you. Moving on, this was a first trimester case. Mrs. PB, she's 39-year-old, gravid 2, para 1, living 1. First scan at 12 weeks in 1 day. And these are some of the intracranial findings that we see. Dr. Pooja, can you take us through the first trimester findings of an open neural tube defect, please?
Yeah, so first we'll start with the key image of the first trimester. That is the mid-sagittal view of the fetal face, and that was mainly used for detecting the nuchal translucency at that time. But with the advent of the intracranial translucency, the first trimester scanning for open neural tube defect has opened a lot of paradigm in early detection of these abnormalities and good counseling. So basically, when we see the head in the first trimester, this hypoechoic area, this is a thalamus, which continues as the midbrain and then the brain stem. Behind that, you would have another equilucent line. This is more equilucent than the upper one, and this is the future fourth ventricle. The echogenic area just below this echolucent line is the choroid plexus of the fourth ventricle, and there is another thin echolucent area below this, and that's the future cisterna magna. And then you have the occipital bone, which can be seen in the other diagram. Now, this echolucent area in between the brainstem and the choroid plexus, and that's known as the intracranial translucency. Excellent finding by Professor Shoei, which is the obliteration of this finding can be used in the early detection of open spinal defects by screening the sign if this is absent. Now, you will see in the next picture, you will see only the, okay. So the thalami, the midbrain, and the brainstem, and beyond that, you don't see those echolucent line which we're seeing in the above image. And this is the obliteration of the fourth ventricle vis-a-vis obliteration of the cisterna magna in severe cases. So you may only see a small area behind this, and this can also be used as for the ratios. That is the brainstem to occiput ratio, or the brainstem itself. And this ratio is more important than the absolute finding, because an increased ratio between the brainstem measurement to the brainstem occiput is an indirect indicator of your obliteration of the fourth ventricle. So that's which is nearly 100% sensitive. The other features in the first trimester, the mid-sagittal views, are the frontomaxillary angle, which because of the caudal displacement of the brain, this becomes a bit more flatter. So this is one sign, which is again an indirect sign. The next mid-axial sign is also the maxillo-occipital line, in which, Shuttle, can you just go back to the first image? So when you draw a line from the maxilla to the occiput, you see a shift of the midbrain below this line in cases of an open neural tube defect, whereas in a normal one, in the other image, which you see, when you draw this line from maxilla to the occiput, the midbrain is above this line. So this is the Simon-Mars indirect sign in the mid-axial view. Then the axial views of the first trimester, the important with a very good sensitivity is the distance between the aqueduct of the sylvius to the occiput. Now, the aqueduct of sylvius is presented as a hypoechoic area between the midbrain. You can see the cerebral peduncles immediately up that, and beyond that, you'll see the thalami. Now, there's a distance between the aqueduct of sylvius to the occiput, and that is fairly good enough and has certain nomograms also. So when in the absence, in the presence of an open neural tube defect, there is a push caudal displacement of the brain elements. So you see actually the juxtaposition of the midbrain to the occiput, fairly decreased distance between the aqueduct of sylvius and the occiput. So this measurements have also nomograms, and it's about 1.7 at the fifth centile at 45 millimeters of CRL, and at 84, which is the uppermost level of the 11 to 14 week scan, it is about 3.7. So this is also a very good sign. Another thing is paralleling of the lines between the cerebral peduncle and the thalami. So there's no acute angle which is seen in a normal case. You will have parallel cerebral peduncles. This is again an indirect sign, and also the same sign has been reformatted into a crash sign, which has been recently published by Professor Pranav Pandya and group. This is nothing but the same juxtaposition of the midbrain to the occiput, decreasing the distance between the aqueduct of sylvius and the occiput. They don't measure it, but they keep it as a sign, so it's easily recognizable, easily measurable. And you can see again all signs, that is the paralyzing of the cerebral peduncles with the thalami, all in one view, can be assessed with one axial view of the brain. So it's not only one view. When you suspect that in your nuchal translucency, which is the common image you take for all the fetuses, you first see the IT, measure the IT, and then of course we are doing the biparietal diameter plane for everyone. So you see the choroid plexus also. Now one more sign is a drying of the brain in this time, and that is the choroid plexus, which fills up the brain over here. You see the decreased perichoroid area. So this is also the drying up, the good sign. The Professor Nicolaides group has also given importance to this sign recently. Overall, and also if you have a big open neural tube defect in your 11 to 12 weeks, there is always a shortening of the CRL. That is also very one important point. When you have a dating scan, which is absolutely corresponding, IT, which is not seen well, a short CRL, BPD, which is not, the choroid is filling up, then you add on all the signs and finally give a compiled view of the baby.
Thank you. Dr. Lula, how would you prognosticate a case of open neural tube defect? What factors matter?
Yeah, so I spoke about, of course, whether it's an open neural tube defect and closed neural tube defect is the first most important thing. And we generally like to see whether there are any intracranial signs. If there are intracranial signs, then it's more likely to be an open neural tube defect. And then you would like to see the defect itself. And if there is a skin covering or if there is no skin covering. The level of the lesion is very, very important, anatomical and neurological level, and probably we should discuss what is the neurological level a little later, functional level. And here you can see that this clip this is by far the one important thing that you must see is the lower limb movements. And this has gone through a lot of changes over the years. People said initially it's useful, then they said it's not useful. But in the MOMS trial and recently also in the International Fetoscopic Convention on Spinal Surgery, it was considered that this is one sign at the time of doing even a fetoscopic surgery or at just before birth. If you see flexion and extension at the hip, the knee, the foot, then there is a good chance that this baby is going to have ambulatory activity ex utero. So we are seeing here that hip flexion is L1, L2, knee extension L3, ankle dorsiflexion L4, and L5 is plantar flexion. And so all these levels you need to, there is a chart available, and usually I just remember that there is flexion extension at the hip, knee, and ankle. Of course, you cannot predict bladder bowel disturbances. So that is one limitation of antenatal ultrasound. It has been seen that this neurological level that we predict, which is affected, is about 2 or 3 levels usually above the anatomic level. So you may have an anatomical level and higher the level above, say like L1, L2, these are the situations where you're going to get a lot of problems. The size of the lesion also, if it's a very large lesion, then the chances of surgery in utero there's going to be a problem. And even the contents of the meningocele, if it's called neural elements, if there's tethering of the cord, so all put together, intracranial signs, functional elements, level of the lesion. And as I already said, intracranial signs, you look for all the various defects which will then, and so if there are many problems as we have outlined, then it's better to offer termination. Otherwise, you could think of in a very, very low level, something like an S2, S4 level with good functional activity, tiny meningoceles, you can consider continuation of pregnancy. Of course, this is a subject which requires a lot of discussion, but this is in brief.
Thank you. Dr. Shilpas, if the patient comes to you at less than 20 weeks and termination is probably an option which you would offer, especially for big open neural tube defects, what after termination? Does the job finish at this pregnancy? What should we do for preventing it in the next pregnancy?
So if I have done an MTP for patient with diagnosed neural tube defects, the first and foremost is examination of the abortus, of the placenta, of the membranes, and the color of the amniotic fluid. I think these all 4 components in any case of a termination should be examined. So we have to do the complete external examination. We will be covering the detailed thing in the next slides. So now prevention in next pregnancy. We all are very much aware of this fact that periconceptional folic acid. So folic acid supplementation is, I think, first and the very important part of fetal therapy, which is actually very useful. So it is one intervention which is very useful. Just to tell that I came across a very interesting paper in 2018, which said that what is the normal thing is we give for a patient with previous NTD, we give the recommended dose is 4 milligram. And in a patient without any previous NTD, the recommended dose is 0.4 milligram. So that is what is the recommendation. But there was a paper which said that actually 5 milligram or 4 milligram is too much a dose. And because it was all done in 1991, so by medical research council, and it was never challenged after that, and we've been following since 30 years, and even I read it for the first time, so I thought I should be sharing it with you all, because they said that even 1 milligram, even with the history of previous NTD, 1 milligram of folic acid in this pregnancy is sufficient. So we have to correct the nutritional deficiencies. vitamin B12 and folic acid. And in fact, that paper also said there are harmful effects of excess folic acid. They said if the folic acid will mask the deficiency of B12 and it will increase the neuropathy. So which was actually a thing which we should actually be thinking about. So that was one thing. Also, I will rule out all the causes of neural tube defects in my present pregnancy. So whether she had any hyperthermia in pregnancy, mainly in the first trimester, because we know fever is an important cause, can cause neural tube defects. We have to rule out not gestational, diabetes mellitus before pregnancy. And any drug history, like mainly drugs like antiepileptics, and in that also valproic and carbamazepine. They are very much responsible for neural tube defects. Drugs like aminopterin, or also drugs used basically for hallucinogen exposure. So these are the drugs which are used, can cause neural tube defects. And in antibiotics, even carbamazepine and sulfamethoxazole is also responsible for giving rise to folic acid deficiency. And yes, NT-scan in next pregnancy. So periconceptional folic acid, NT-scan, that is a mini anomaly scan, which is now we are doing at 12 weeks. So to rule out early signs of, as Dr. Pooja and Dr. Chandar had already said, the early signs of neural tube defects.
Thank you. Dr. Shruti, in which cases of neural tube defect should we involve you? Are there any red flags where we think a geneticist needs to be involved, since seeing that most cases are usually multifactorial? And should we offer investigations to all cases of isolated spina bifida?
Yeah. So especially when we look at the genetics of neural tube defects in congenital hydrocephalus, it's really a whole spectrum, right from environmental to polygenic multifactorial, where there is a gene and gene environment interaction. And on the other end, there are proper high-end monogenic disorders where it's purely genetic and there's no role of environment. If we look at most of the anencephalies and open neural tube defect and non-syndromic hydrocephalases would fall in this zone of polygenic multifactorial, where although the risk of recurrence is present, we say it's empirically around 3 to 4%, it's not the way it is in well-defined genetic syndromes. On the other hand, presence of occipital encephalocele in the recent literature has come as a important red flag by itself to suspect single gene disorders. They are an important clue towards underlying ciliopathy group of disorders. Again, as it's been highlighted, syndromic neural tube defects, syndromic hydrocephalases are always clear red flags. Important point is that even the non-syndromic hydrocephalases, there is a fair amount of literature which now supports that even non-syndromic hydrocephalases should be, next slide please, that's okay. Should be a red flag. So if I was to summarize the important alerts, so any family history, if there is a previous sibling with the same history or another family member having a significant pedigree, syndromic association, occipital encephalocele, next point please, and non-syndromic hydrocephalasis, because we know now that there are a lot of genes which are associated even with isolated hydrocephalasis, and importantly, they have autosomal recessive and X-linked recessive inheritances, which means that the risk of recurrence could be as high as 25%, as against the 4% which we were speaking for the multifactorial etiology. This is just a picture from a very interesting paper which shows the genes for the non-syndromic hydrocephalus. Vis-a-vis the syndromic hydrocephalus, this is one of the other syndrome known as crash syndrome, which is for hydrocephalus with aqueductal stenosis. That's commonly seen just a hydrocephalus with aqueductal stenosis. But if you see red flags, as in this case with macrocephaly, it becomes an alert towards a genetic etiology. Next slide, please.
I think that's
yeah.
Thank you. Even though we have very good first trimester signs for detecting open neural tube defect, late detection of open neural tube defect is still a very unfortunate reality. Many times, because the anomaly scan itself gets done after 20 weeks, termination of pregnancy is not an option that we can offer this such a patient. So in such cases where the diagnosis is made late, Dr. Shilpa, what sort of an antenatal plan would you make for such a pregnancy?
For these patients, basically the routine plan, the routine obstetric care is not very different from what we follow for other patients. Polyhydramnios is usually seen mainly with anencephaly and not that much with neural tube defects. And yes, hydrocephalus is a component of anal chiari malformation too. Now, depending on now for mode of delivery, I have to consider 4 or 5 factors. So one is what is maternal request. So we have to take into consideration what is her wish. The second thing is whether there is an associated megacephaly or hydrocephalus where I cannot deliver her vaginally. The third is whether the presentation is breech. Usually with these neural tube defects, the neuromuscular movements are restricted or affected, and that is why the position usually is breech. And also because the head is big because of hydrocephalus, the head occupies the fundus and the breech occupies the lower bole. So usually the presentation in neural tube defects is breech. So I have to take into consideration whether it is a breech presentation, whether it is a large head, whether there are any other associated obstetric indication for the mode of delivery, and what is the maternal wish. So considering all these factors, we have to take a decision whether I will go for a cesarean or normal. Normal delivery, though, is not contraindicated, but as we see in all other cases, they usually end up with a cesarean section. There was one study which said that the size of meningomyelocele sac also affects the mode of delivery. So if it is say less than 6 centimeter, though I never found a proper evidence-based study on that, but if it is less than 6 centimeter, they said we can go ahead with the for a vaginal delivery. Whereas if it is more than 6, you should not attempt a vaginal delivery. So these are the things which we should be considering when we are delivering. Also, there is one point that in mom's trial, for meningomyelocele repair, they actually delivered everyone with cesarean. So said they delivered everyone for a cesarean, even the prenatal group where the repair was done and the postnatal group where the repair was done, because they wanted to remove that bias of mode of delivery in the timing of repair. So they actually delivered everyone by cesarean. So I think cesarean, in case if we are looking at the repair and all, so cesarean is an option.
Thank you. Dr. Nakul, could you explain briefly the management of such a unit? What complications would you anticipate? Is it okay to deliver at a local nursing home and then transfer the baby, or is a tertiary care delivery essential? What are the challenges that you would face? At what point of time would the neurosurgeons be involved, and what are the indications for offering compassionate care?
So with all the detailed antenatal screening and antenatal assessment that we have done, if at all we are coming up to a diagnosis and we are aware of a problem, the first and foremost thing should be a very good antenatal counseling, which should be with a multidisciplinary team involving the obstetricians, the maternal fetal medicine specialists, a pediatrician or neonatologist who has been dealing with such surgical cases. And just to explain the family, the prognosis, the surgeon should be there, and genetic counseling obviously is essential since there is high chances of recurrence. With the place of delivery, the only primary aim with these babies is to preserve the and have the best neurological outcome. So there are high chances of getting these lesions getting infected and worsening the neurological sequelae. So it is really not safe for these babies to be delivered elsewhere in a small nursing home and then being transferred. So the ideal and the safest way would be a tertiary institute wherein they have the surgical services, the baby being delivered there, and the care subsequently has to be continued there. Aim for delivery at term, they are really, Dr. Shilpa has explained the mode of deliveries, the options that we have. But as we said, that is based on individual cases and an individual assessment by the obstetric team actually. Now coming to the postnatal management, the goal of for neurosurgical closure at around 24 hours, within 24 hours, as soon as possible. So the resuscitation for these babies will be as usual as the other babies. The focus should be to cover the lesion with a non-adhesive, sterile, and a saline-soaked dressing to make sure that it doesn't dry off and it's not infected. There are increased risk for these babies to go into hypothermia because of the excessive insensible fluid losses, babies being cold because of the nursing issues, obviously. As previously discussed, these babies have to have a very detailed clinical assessment and a structured neurological exam, especially once the initial stabilization is done. So they will need to be assessed for their tone, the muscle bulk, and the consistency in the lower limbs, the movements and the position of the hip joints, knee joints. The lesion should be checked specifically for any CSF leak. The head circumference should be measured and serially measured, in fact, to make sure that it is not increasing rapidly in size. The anal tone and the urine has to be observed. Sometimes even a tight sphincter does not indicate normal function, and these babies do have anal incontinence and urinary neurogenic bladder. So all these things have to be assessed pre-operatively, and prognosis can be guided through these things. There are increased risk of infection because of these lesions, and these babies should be covered with prophylactic antibodies and antibiotics prior to perioperatively. And the routine newborn care, pre-operatively, they will need good imaging, a CT or a MRI, and a renal imaging has to be done before, post-operatively, before the baby goes home, ideally in the first 2 to 3 weeks of life. Now, dressing, again, because of the lesion, it becomes very difficult to nurse these babies. Often these babies are nursed either prone or on their sides. The sac has to be kept moist and covered well with a sterile dressing. Otherwise, we may lead in a situation wherein there's a shock-like state of the spinal cord. So what we used to do was just use a butterfly needle, break the needle and put the butterfly inside the dressing in between the two layers of the dressing, and just keep infusing it with small amounts of warm saline very frequently, like every hour or every 2 hours. So these are all pre-operative, and then the surgical measures will be discussed with the best by the surgeons.
Right.
But this is what we would do just to stabilize before the baby goes to the theater.
Thank you, Dr. Nakul, for giving us such a clear picture. Dr. Biani, could we involve you, please? What is the management plan? At what time would you close the defect? And what are the indications for shunt, contraindications for repair, and follow-up plans?
Yeah, main purpose of the treatment so that we can prevent the ascending infection and have a healthy skin cover so that the nursing care can be done. Okay, before we tend to operate, we wait for 24 hours to make sure that there is no other congenital defect associated with the neural tube defect, like a heart or GI or other associated defects with the kidney, and the family has to be counseled and the surgery is instituted. 30% of the children are born with hydrocephalus, where treating the hydrocephalus becomes precedent, and then the MMC repair is done in the same setting. And 40% of the children, they develop hydrocephalus after the repair of the meningomyelocele. It takes around 10 to 14 days, and once the hydrocephalus develop, we have to treat it with a VP shunt. 30% of the patient would not require any treatment for hydrocephalus as well. The contraindication for the treatment is a very high defect and the family not willing for any further treatment. Usually this the multidisciplinary follow-up where they have an associated neurogenic bladder and bowel, and also the neurogenic defect in the lower limbs, which are actively and aggressively managed by physiotherapists and pediatric orthopedics.
Thank you, sir. Coming about a short discussion of what can we do for these babies intrauterine. Could you highlight about the mom's trial, Dr. Lilla?
Yeah, so this trial was started way back in 3 centers in the USA, where they started with open surgery, hysterectomy surgery, And then now, of course, most centers have switched over to either laparotomy, fetoscopy via laparotomy, hysterotomy, or percutaneous fetoscopic repair. And the management of meningomyelocele surgery trial is called the MOMS trial, and it's been a landmark trial because it has shown conclusively that if you select your cases well between 19 and 26 weeks, and if it is a low level defect between T1 and S1, and you can do an antenatal repair, and this will prevent whatever Dr. Bayani was talking about, that the hydrocephalus can be prevented, you less requirement of ex utero shunts, ambulatory movements can be better expected, your motor levels and your neurological levels will be 2 to 3 levels higher as compared to what you would expect if you do ex utero surgery. So definitely it's the way to go. And I think Dr. Pooja and Sheetal will show a clip little later. But fetoscopic surgery is today, the open hysterostomy surgery had a lot of problems in the sense that you could not do a vaginal delivery. The uterus could have a scar dehiscence, so there was no possibility of vaginal delivery. The aim of doing a fetoscopic repair is to give the chance of the mother to a later delivery beyond 37 weeks, and also a vaginal delivery. So most of the recent papers on fetoscopic repair are all talking about a 70 to 80% of these babies being delivered vaginally. So, and you can see here, if there is prenatal surgery versus postnatal surgery, you have the need for shunt is much less. If it's prenatal, it's about 68% versus 98%. And even hindbrain herniation reversed in about 6 weeks when you do antenatal surgery, and may not reverse after postnatal surgery. And of course, IQ levels also are affected, I mean, equally in both the cases. But and the other thing is, in open repair, there is a larger chance of seeing cerebral palsy in the baby. So it's now conclusive. Most of the centers begin with open hysterotomy repair as an initial method, and then they slowly move over as experience takes over with the fetoscopic repair, either percutaneous or with hysterotomy. So the way to go is, of course, but it's easier said than done. There are very few centers across the world which have the expertise, and I think India, we should start developing these. So that the future is definitely antenatal surgery, because the results are better ex utero, and the surgeon can deal with these babies better and gives hope to the parents to continue these pregnancies also. Otherwise, most of the times we are terminating these pregnancies.
Thank you, sir, for giving us an overview of how this all antenatal surgery began. Dr. Pooja, as Dr. has alluded to, could you describe about the endoscopic in utero repair of the meningomyelocele?
Yeah, so in the endoscopic in utero repair, instead of the hysterotomy, they applied the fetoscopic procedure, where the uterus was pierced by the Saldinger technique by 3 ports. The endoscope about 3 mm, and the 30-degree scope of about 2.7 to 4 mm was used. After visualization of the area of the open neural tube defect, the neural placard was seen. It was teased away from the skin by the circumferential area where it was tugging to the skin. It was again undermined more so that they could approximate the skin over the placard. Now, the neural placard was then covered with a biocellulose mesh, and that was the mesh which was used to cover it. Now, if the defect was more a larger defect, the approximation of the skin would have been difficult. So they used a skin substitute along with the double layer closure of the biocellulose membrane, which was covering the placard. The skin was then sutured with a monofilament, which was non-absorbable, and a continuous suturing was adapted to it. After this, the uterine ports did not require any further closure, and this was all under a partial carbon dioxide area, which was used post the fetoscopy, the mothers were in-house for 3 to 4 days, ambulatory after 1 day. So it was really an innovation, but definitely the learning curve, which they say is a far big learning curve. The CCAM trial, which affect the difference is not much significantly. That is, both had equal good cases of hindbrain reversal, hindbrain herniation reversal, and decreased use of VP shunts. But what they found was a significant premature rupture of membranes in the fetoscopic group, because the moment you are inside, the longer the time you are in with the fetoscope, the larger is the leak of amniotic fluid, and larger case of infections and preterm delivery was seen more in the fetoscopic case rather than the hysterotomy case. Apart from that, the uterine dehiscence, as Dr. Chandar said, was more in the hysterotomy, and this required a C-section, which was not seen in the case of fetoscopic surgery. So actually balancing the fact, Professor Jan Deprez, who is part of the old trial, says that there is the significant change, there's not significant difference between fetoscopic versus open so far. They need more cases to say which technique is better than the other. However, we do have a greener area to look forward to, where we didn't have any hope in open neural tube defects. So this is going to be learning course in terms of antenatal assessment or treatment of open bifida.
Thank you so much for that overview. And with that, we conclude our first case of open tube defect and begin the next. So here is Mrs. VN. She's 23-year-old, gravida 2, para 1, living 1. At 18 weeks, 5 days, she came for a second opinion saying cystic structure seen in the lumbar area separate from the spine. The quadruple test was done where AFP was normal, and then she was sent for a second opinion. Dr. Rajini, can you please go through the scan findings with us, please?
Yeah. Here you can see there is a cystic lesion that is seen at L3 level. However, we can see that the spine curves, the lines that I was talking about previously, are still seen. And this is has a covering of skin along with it, which is exquisitely demonstrated on this image. It's also, the skin covering is also seen on the actual view that is seen here. But there is a slight splaying of the posterior elements that is seen on the actual image, and the lucent area that is connected to this cystic lesion is apparently going within the spinal canal. As Pooja was saying, we can see that the cord is seen at a lower level. That is seen on the first image. Again, the second one shows the cystic lesion with the skin covering very well. And that's also seen on the tethering of the cord is better appreciated on the last image. Unlike the first case that we had seen, which had ventriculomegaly and the lemon sign and the banana sign, on these actual images of the fetal cranium, the cerebellum is seen quite clearly, the cisterna magna is seen quite clearly, and quite obviously there is no ventriculomegaly. The choroid plexus is seen nicely filling the ventricles.
So hence, this is a case of a closed neural tube defect, mainly a lumbar meningocele, and hence, because it was closed, the AFP was normal. Dr. Pooja, how will you counsel such a couple? How would you go about managing this kind of a feature?
This is a case of a closed spinal dysraphism, where you have a meningocele at the lumbar region with a skin covering on it and normal intracranial signs. So again, you see the baby from head to toe completely to rule out associations which are commonly associated with neural tube defects. So that is one aspect. Counseling will always be a team counseling, along with the the pediatric neurologist and the pediatric neurosurgeon. But before that, because of the tethering of the cord, the prognosis actually shifts a bit, and that can be confirmed by the MRI along with your ultrasound. Now, usually some centers only use ultrasound as to diagnose tethering, that is the lower level of the conus and the shift of the central canal of medulla towards the laminae. So when tethering is there, this is a continuous process. The spine is actually growing. It's just an 18-week baby. So the effect of this tethering on the neural structures, on the neurological deficit, or the bladder or bowel dysfunction cannot be predicted at the same time at 18 weeks. So a counseling after a good MRI and ultrasound with the neurosurgeon is a must when you counsel such couples, to not give them a very bad picture, but at the same time not be very positive because of the tethering of the cord, which you can demonstrate on ultrasound. So it will be a team effort. And will you offer invasive? Again, as Dr. Shruti Bajaj has clarified, that if there are no associations with this kind of finding, the cranial signs are normal. So it's not a case of hydrocephalus. Usually we don't offer amniocentesis in an isolated closed neural tube defect where you don't have any other associations documented at the 18 to 19 weeks. However, and also this is a gravida too. She has a first normal kid. So, and the pedigree, which we don't have over here, but I assume that that would be normal. So in the case of everything which is fine, we don't offer invasive in all procedures.
Right. Thank you. Dr. Pawar, how would you counsel this couple antenatally, and what information from the ultrasound would help you with your counseling? Is there something which you specifically look for when you look at a scan finding? Would you prefer looking at an antenatal MRI when you counsel such a couple? And how would you manage such a baby after birth?
Yeah, thank you, Sheetal. Like Dr. Pooja said about the counseling this couple antenatally, we know that the prognosis is going to be better than that of an open neural tube defect. But parents don't really care what is the outcome of a closed and an open. My closed defect is much better than open defect and everything. They want to know how their kid is going to behave. They want to know whether their kid is going to be ambulatory or not. And this, like Dr. Vazirani said, that we have to, this all is determined by the level of the lesion. A higher lesion and a lower lesion is going to make a difference on the level of ambulation that we're going to have. So I would definitely give a picture because there is tethering. I would be very guarded in my prognosis. I would definitely tell them that yes, there may be a significant issue of ambulation and of continence, of the urinary continence and the bowel continence. Because this level is quite higher, it's not a low sacral lesion, so we have to give it very clearly. What information I would need from the ultrasonography is just like Dr. Vazirani said, any associated problems if they are present about the kidney, if there is any genetic malformation that is showing some other malformations are there, it would point me towards a more graver prognosis. But because the maternal alpha fetoprotein is normal, I am quite sure it is a closed defect. Antenatal MRI is a different issue altogether. I'm not looking to operate this kid immediately after the surgery, after the delivery. So I still have time to do an MRI afterwards. There is no emergency involved in doing the MRI. See, there is a lot of issues with the fetal MRI, the movement of the kid, the sedation that you're going to give, and all these things are there. The clarity of MRI is still going to be affected as compared to an MRI that is done once the kid is delivered. In SRCC, we are hardly doing any kids under sedation. We are usually preferring to do the feed and wrap method of doing the MRI, so that there is no element of sedation given to these kids. You can just feed them nicely, have a nice atmosphere, wrap them tightly, and do the MRI without giving any medication or any sedation. So antenatal MRI, yes, but I would not be in too much hurry to obtain it. Some MRI that I can obtain after the delivery. Mode of delivery, like someone said earlier, I would prefer a cesarean section if the size is more than 6 centimeters. If it is smaller than that, it does not matter if it is a vaginal delivery also. There is no associated ventriculomegaly, or they are not looking at a hydrocephalus, so it can be delivered in a normal delivery also if the size is not very, very big, more than 6 centimeters. Place of delivery and timing of surgery. Place of delivery, again, does not matter. I don't need to have this kid deliver at my center where I have to operate immediately. There is a nice, because the timing of surgery is usually 6 to 9 months of age. So it does not matter if the patient is delivered at another center. Definitely institutional delivery, not a home delivery. But other than that, does not need to be a tertiary care center where the kid is delivered, like at our center or with a level 4 ICU. The surgery details, there are too many variations in the closed neural NTDs. Of course, it can be with a mass, without a mass, if there is any diastematomyelia involved and everything, the surgery changes the plan with that. Usually we operate between 6 to 9 months of age. This is so that the kid can tolerate the blood loss that is going to happen. The kid will be much more bigger and tolerate the surgery better. Outcome of tethering this tethered cord is better than that of open NTD, but yes, definitely we still have to be giving a guarded prognosis because it is still tethered and has a chance that it might affect the ambulation and the continence of the kid. Prenatal diagnosed versus undiagnosed, usually we have a better outcome prenatal diagnosed because the mother can be more watchful for the signs of the limb movement, or there is any dribbling of urine, or if there is any constantly wet cloth. So this gives an idea whether we need to intervene a bit earlier or not.
Thank you so much. So Dr. Shilpa, we already know that the surgeons do not want us to go ahead and do a cesarean here. Do you have anything other specific obstetric care that you worry about in such cases?
The routine obstetric care. And just one thing which I want to add in the mode of delivery is, so there was this study which they compared the patients delivered by cesarean. So they found that the anatomical lesion and the functional lesion, so actually when the anatomical lesion was little higher, the functional lesion was 3 segments below the anatomical lesion. That means the severity was less than what the anatomical lesion was. So that was they found in when they did a cesarean. And when it was a vaginal delivery, the anatomical lesion and the functional lesion, there was only 1 segment difference. But again, they said that it could be a bias because the vaginal delivery patients were non-compliant. And that is the reason why they actually were not very much keen on having, proper care. And that is the reason why they had only 1 segment difference. So that was one thing which I came across, that when you have a cesarean, the anatomical and the functional level of the lesion is considerably different when you have a vaginal delivery. So again, it all depends on the individual patient.
Thank you. Just a sec. Dr. Nakul, is there any specific concerns you have for this baby? Would you want to see these babies immediately after birth for some reason?
They would definitely need a detailed assessment just for prognosticating purpose and to time the surgery. If at all there is any leak, or if we are seeing that there are some more problems than what we anticipated antenatally, they would definitely need the intervention sooner than later. But the follow-up assessment will definitely be, we will be looking at the head circumferences, and we would be looking at the urine and the anal incontinence and how that goes. They will need a detailed follow-up, including the therapist, the physiotherapist, the neurosurgeons, and the neurologist. They will all be involved, and they will need very close follow-up.
Thank you. So that concludes the second case of the closed neural tube defect. And now moving to another case, which is at the other end of the spectrum. Here is Mrs. KS. She's a primary gravida, non-consanguineous marriage, and no previous history. She came for a second opinion for an occipital encephalocele. Dr. Lilla, could you please describe the findings and take it on from there?
Okay, so we can see that there is a large cystic mass lesion seen in the occipital area, with presumably an occipital defect, bone defect. I think so. This is an occipital encephalocele with, you can see that the skull is small. There's posterior herniation of like a kind of tectal beaking that is also seen, and you can see that the contents are all outside. There's a large cystic element, and the brain is very small. So very typical for an occipital encephalocele. And you can see the typical enlarged echogenic kidneys, cystic kidneys, which we would see in Meckel-Guber syndrome. And so this is syndromic involvement of, there is no polydactyly, but that can happen sometimes in ciliopathies. All the 3 elements may not be there. So this is a typical ciliopathy with Meckel-Guber, or autosomal recessive with a 25% recurrence. And the important thing is that it is syndromic, and we need to counsel the parents that this is a recurrent disorder, and so they need to check in every present. But the important thing again is that can be now a first trimester diagnosis. So you can pick up these pathologies in the first trimester and can be terminated, and the mother can be brought back in the next pregnancy early for early detection. So that's important when you look at these things. These are all first trimester detections now.
Right. Thank you, sir. So this pregnancy was terminated. These are the postnatal findings. And since, as sir said, it was a suspected genetic etiology, the DNA was stored and sent for a clinical exome. And this fetus, as predicted, turned out to be homozygous for Meckel-Guber syndrome. Dr. Shruti, here this was a very obvious case because it had a syndromic association. But are there any other red flags as far as occipital encephalocele are concerned?
as I already highlighted in the previous slide, occipital encephalocele even by itself would be a red flag to look for single gene disorders. And as Dr. Lulla rightly said, that you may not really get the entire string of findings. So even if you're getting a pure isolated occipital encephalocele, it should be considered as a red flag. And if one is not sure about what test has to be run, as in this case, at least the DNA can be banked and can be used prospectively later on for doing the test. Often we face these dilemmas to what should be the test which should be offered. And one of the common myths is that a whole exome sequencing is all encompassing. And if one does the whole exome, one does not really need to look for microarray or karyotype. So this is just that, just for the viewers, that microarray picks up copy number variants, aneuploidies at macro and relatively microscopic levels, whereas clinical exome and whole exome picks up single gene disorders at single nucleotide variants, basically. And these reports have to be, without saying, obviously interpreted very carefully, because sometimes there are results called as variants of uncertain significance which come forward. In the previous discussion, it just skipped my mention that 40% of the hydrocephalises in all have an underlying genetic etiology, while only 10% of them are actually syndromic. So, just to say that in all these cases, the right application of the genetic test can really go the distance in establishing the diagnosis, which in turn can have a role in surveillance of the other morbidities, discussing the candidacy for the surgery, who should get operated, who shouldn't, and of course, the risk of recurrence for the future kids, as in this case.
Talking of recurrence, I thought you wanted.
Yeah, this was an actually interesting case where this unfortunate couple had all the 3 pregnancies ending with anencephaly. Being diagnosed with anencephaly in the early scans and being terminated. So usually, as my previous slides highlighted, anencephaly is usually considered to be multifactorial because of a mix of multiple factors. But here the pedigree was very, very suspicious, where you're finding 3 back-to-back pregnancies ending with neural tube defect, and that too with a full-blown anencephaly. So here we were suspecting an autosomal recessive condition. The clinical exome revealed the mutation in the MTHFR gene as well as in the T gene, both of them having very important role in the normal neural tube formation. However, these variants were variants of uncertain significance, and so the couple is still in the go of trying to reclassify the data. However, the case, what I wish to highlight over here is that in the presence of a family history, one really needs to then think beyond just the routine multifactorial. She just kept on getting folic acid even after the second anencephaly, and really the whole genetic etiology and the angle wasn't thought about early in this case. So this was just an unusual case which I thought would interest the listeners.
Thank you so much. Dr. Shilpa, can you just very quickly go through how we go about sending these tests? Because unless we send them properly, there'll not be enough DNA to work with. So how do we go about investigating the abortus? Can you quickly take us through that, please?
We are doing the fetal autopsy. The first and foremost is take the consent. Parental consent is very important, and not necessary. If they have not given any consent for a complete autopsy, then we can do a limited autopsy. So what is limited autopsy? Limited autopsy is where we gather as much as information as possible from the fetus so that her next pregnancy, we can manage it well. So we have to take all the clinical photographs from the not only of the lesion but also the face, the facial profile from the side, from front. So each and every part should be taken in detail so that we can study it and we can corroborate all the findings together. And autopsy should be, we have to send the fetus immediately in formalin, but we have to remember that if you want to send the sample for DNA store or microarray, then we have to remove the sample first and then put the fetus in formalin, because the sample will go in normal saline with or the culture media provided by the lab with antibiotics added into it. So then we have to send this, and again we can have the fluids from the cavities. So we can take any serous cavity, if there is edema or any blood or any fluid in the abdominal cavity, we can take that, and we can have biochemical, morphologic or any hematologic assessment of that fluid. So we should be getting whatever information we can. And coming to the radiology part of the autopsy, we can have X-rays, we can even do fetal MRI. So we can also do an MRI of the abortus to see if there are any findings which we have not picked up on ultrasound. So either an MRI or X-rays is also, it would be very helpful.
Right. Thank you so much. So that was a case at the opposite end of the spectrum with a very, very poor prognosis. And coming back to our last case, Dr. Pooja, could you please take us to this finding since this is your case? Dr. Pooja?
Pooja, unmute yourself.
Sorry. So this was a highly, she was grossly diabetic, obese lady, very high BMI, and had come for an anomaly scan at 17 to 18 weeks. And usually with all the sagittal, the coronal and axial imaging, which is the hallmark of spine imaging. So that is the time, this was the early fellowship days. And in the coronal image, we could see more flaring of the lumbar spine with osseous echogenic area in the center. Now this is a very good hallmark on ultrasound for a split cord malformation or a diastomatomelium. Now you can either have a very fine area over here, just mildly echogenic, that can be a cartilage or a fibrous tissue. The crux of the finding is in the coronal area, you find an echogenic area, do it your 3D rendering, and in the axial region, you can actually see the osseous region in the spinal area. Now this can be of different varieties. One actually type 1 has different hemichords splitting the entire cord into two with a separate dura, and the type 2 is the single dura with a split cord. Now and after that you will see the normal tapering of the spine below and the fusion. So this is hemichord, hemichords on each side with the osseous area in the center of split cord malformation, type 1 or type 2 depending on the ultrasound picture. Again, this should be again subjected to MRI, because MRI will give us a clear indication about the type of diastomatomia, the importance of tethering, because 75% of these cases are associated with tethering of cord, and that will be your crux of counseling along with the neurosurgeon. So split cord malformation, yes, cases do have a favorable prognosis, but that depends again on the associations along, because they're also present with other spinal abnormalities like segmentation defects, hemivertebra, or a tethering of cord. So it is again the same kind of approach to any closed neural tube defect, and the neurosurgeon will be the best person to tell us more about the prognosis when you have type 1, type 2, and how do we actually, when we have a combined sitting, what are the grave prognosis and what are favorable prognosis in these cases.
Right. So, Dr. Biani, would you like to handle these questions? How would you counsel and prognosticate this case? Follow up at what age, and how is the neonatal management?
Now, thank you. The category split one, type 1, that's with the bony spur, and type 2, that's without the bony spur. But in both the cases, the cord is always lying low. So you have a low lying conus with a bony spur or without a bony spur. So all the children have a tethered cord element, but since it's a closed neural tube defect, and since the defect happens in the gastrulation, the spinal cord is not exposed to the amniotic cavity when the child is still in the womb, the prognosis is much, much better. Associated vertebral body anomalies would not change the prognosis or the outcome of the surgery. They would have a kyphoscoliosis, and that can have a deformity. Usually, the children are born without a neurological deficit. At birth, we see the neurofitness marker, and almost more than 95% of these children have a hairy patch with a healthy skin and a good lower limb movement. There is no rush of getting an MRI immediately at birth. We do a MRI at around 3 to 4 months, and a detethering surgery is done at around 6 months before the child starts sitting with and without support.
Right. So antenatally, are there any specific findings which might help you prognosticate these cases? And would you prefer that we order an antenatal MRI for these babies? And
actually, if you see, the bony spur is nicely picked up on an MRI. the MRI is not very good to pick up the bony defects, you know. So USG done by a fetal medicine expert is much having more specificity and sensitivity than an fetal MRI. The role of fetal MRI in this particular cases are to have a better structural imaging and see the tethering element in the low lying of the spinal cord. But even if there is a USG, that is fair enough for us to prognosticate.
Dr. Bayani, can I ask a question? Sheetal,
Yes,
can
sir.
I ask a question?
Yes, sir, please.
We have been all through hearing about tethering of the cord and the attempt to antenatally know, but I think we don't really need to know, because all cases of open, closed neural tube defect, diastematomyelia, as a rule, will have tethering. So really, do we need to chase tethering on an MRI? I don't think is necessary, and an ultrasound is good enough to prognosticate, because MRI is only good for intracranial to rule out any cortical disorder. But as I know and as I've heard fetal surgeons talking, tethering is always to be expected. Dr. Bayani, could you elaborate on?
Yeah, neural tube defect has 100% tethered cord actually.
No, I'm talking about even closed neural tube defect and diastematomyelia or such things.
Yeah, closed neural tube defect as well, you know. So
that's right. So we don't really need to
all
chase.
The neural tube defect has a part in.
So I would say, from the point of view of MRI, really, unless you're really worried about whether is there diastematomyelia or not, we don't need an MRI with good ultrasound today with high frequency probe ultrasound.
Exactly, that's what I was trying to tell. No, exactly. That's what I was trying to tell, that we don't chase the fetal MRI. We need to have a good sonography, and sonography is very good in picking up the vertebral body defects and also the bony spur. In fact, MRI usually has a false negative test in that. You
know? I would also like to know what is the long-term prognosis of tethering. I mean, how many surgeries are required? Till how long do these children need to be operated, or what exactly? That's one question. Second question, I don't know whether there time, Sheetal, for me to ask you a question.
This is very much the last slide. Yeah.
Oh, okay. So that's the first question. And secondly, very interestingly, I came upon the fetoscopic surgery time limit is usually 3 hours. Anything more than 3 hours is bad prognosis. So how does that relate with ex utero surgery? How much time do you all take? I'm sure it's much less, but fetoscopy is 3 hours. And I think Pooja also will verify this, that now they are doing 3-layer. I think she already spoke about it. 3-layered repair versus 1-layered repair. And the CSF leak is much less with 3-layered repair. With the bionic material, myofascial closure and skin closure. So I think the future is there. So Dr. Bayani, would you elaborate on all?
Yeah, so we go step by step, you know. So we have to differentiate an open neural tube defect and closed neural tube defect. Open neural tube defect is the meningomyelocele or a myeloraxis that we see, and the closed neural tube defect has a big umbrella of diseases like a lipoma, spinal cord lipoma, fatty phylum terminal, bony spur, without bony spur, the split cords or diastematomyelia, or dermal sinus, neuroenteric cyst, and lipomeningomyelocele, you know, the spinal cord lipomas. So all this neural tube defect, if it is the cord during the embryogenesis is not exposed to a mesenchymal element, meaning the lipoma, the cord is normal to start with. If we see the bony spur, diastematomyelia or dermal sinus, that's the defect in the gastrulation. And if we see the lipoma, they are the defect in the disjunction. So the most important thing that we look during the prognosticating the things and the MRI is the myelodysplasia that happens to the cord. So now, because diastematomyelia is the cord has never been exposed to a mesenchymal element, the prognosis is 100% good. Surgery, only one surgery is required. During the surgery, we remove the bony spur and we also release the low-lying conus. And if it is without the bony spur, then we just release the low-lying conus. So there is no repeated surgery, and the surgeries are quite quick. Unless it's a complex lipoma, most of the surgery they take less than 2 hours time, duration-wise.
So tethering per se does not dictate like how long are these patients going to suffer? or I mean,
No,
because it's always
during
going
the
to be there.
surgery, we just detether. Yeah. There is always going to be a non-neural fibrous tissue that tethers the cord. Tethering means it is catching the cord from ascending up. Once you release that, the problem comes is that when we keep them in the follow-up, the cord that has been stretched down, like conus has come down to L4, L5, it is not going to go back to the normal level. But again, it is not in a tethered position as well.
Some studies say that when we follow up these children in the later stage, do the signs of tethered cord, like neurological signs, do they come later after surgery, 6-7 months or 6-7 years? Like, how's the follow-up, sir, when you have detethered a cord and those children coming to you at a later age? So some studies do mention that. So if that is clear, then the counseling is really good for us, because so far we were thinking that deep tethering of cord may not give answers to the effects of tethering. So we would like to know that from you. How is the follow-up?
Exactly. So now we have to compare apples and oranges. We cannot mix them. So one is a meningomyeloscale of a group of open neural tube defect, and another is a closed neural tube defect that consists of a diastematomyelia, lipomas, fatty phylum, and lipomeningomyelocele. So meningomyelocele, when it is adequately detethered, the follow-up, we look for 4 symptoms that is an evidence of a retethering of the spinal cord. Okay, so all the 4 symptoms are: number 1 is a pain in the back. Usually we see at the child who is around say 7 years, 8 years, or 9 years. When there is a prepubertal growth spurt that happens, and that is specific to the back only. Then there is the onset of a new neurological deficit. Suppose the child has a deficit of L5, and then there is a new L4 or L3 deficit, motor deficit or sensory deficit happens. Then we know that, okay, the retethering is causing the symptomatology. Number 3 is the deterioration of a urological function. Most of these children have a neurogenic bladder, but when the post-void residue starts increasing, suppose the post-void residue was 20 ml and the child was under a pediatric urologist follow-up, and now we see that it is deteriorating, or a VUR, the vesico-uteric reflex has come in, then we are worried. And the 4th is an incidental finding that we see in a follow-up MRI, where you have a terminal localized syrinx. So unless we have this 4 gambit of symptoms and clinical finding, the low-lying cord is not retethered. The cord is lying low and is absolutely fine with the child. Now, these are all that I was talking. What the percentage of detethering surgery that we do? Probably less than 10 to 12% actually. Okay.
And
now coming to the closed neural tube defect like diastematomyelia and fatty phylum or lipomas, we hardly ever have to do the detethering surgery. First surgery is the good surgery for them.
So
Thank you, sir.
Dr. Bayani, as an ex-utero surgeon, how open would you be to doing fetoscopic repair for these? What is your opinion? Although it's not started in India, there's no center doing fetoscopic surgery. What is your...
Actually, when I was in San Francisco, I visited the San Francisco center also, where they were doing the MOMS trial, and the MOMS trial was just started up. But the purpose of the MOMS trial was, if we can prevent the neurological deficit, if we can prevent the hydrocephalus formation, and also the carry herniation. There were the 3 primary end results that they were looking at. Okay, and the MOMS trial had to be abandoned halfway actually, because the morbidity in the mother was much higher. Still we are learning. The Brazil, we have got very good results. Miami, we have got very good results where they are doing with the fetoscope and all those things. But the problem is that the same results have not been replicated in London or Paris or even at the Hamburg places where they have do a volume of fetal medicine work actually. So still it is in the I would say it's a nascent stages, and we are looking forward for the more data for it.
Well, most of these centers are showing excellent data, in the sense, I don't know whether it's acceptable to have a baby which has got a little bit of ambulation with crutches or with this and that, or, the supported micturition, supported defecation. So, and they always show nice pictures.
Mobilization.
They show nice pictures of babies jumping around post surgery. That this baby was operated prenatal and now is jumping around. But of course, they can have cerebral palsy. They can have other problems. So, the results are quite encouraging. But I'm not sure how our parents would accept a child who is yet handicapped, though less handicapped.
No, there is a slightly selection bias as well. The places where they show the good cases are the milder variety of the meningomyelocele as well. The low low sacral ones actually.
Of course, there has to be a selection.
So unless,
but in your experience, how do the parents accept the results of surgery, even if it's ex utero, and you tell them, look, they may walk a bit with support, they may do this, they may do that. What is their do they have hope, or I mean, like, how does it happen? Like, what is the counseling like?
Luckily,
you
in
must
India,
be facing
the
a lot of
accept them quite well.
Okay, so they are
there is a quite good thing. The only problem comes is the repeated follow-up, and in India, the health is to be covered by the family itself. Unlike abroad, what happens is that here every time they have to, that's a big socio-economical burden that we find. At SRCC, we have a spina bifida clinic where it's a multidisciplinary approach to the children, and we are getting very nice result actually.
So that gives food for thought to Rasik to think about antenatal spinal repair, and even both you and Naresh to think about fetoscopic repair.
My thoughts, if I may, to this are a little bit more not so positive. Like, from what I understood, when I was in Canada, that center there was just trying to set the meningomyelocele repair at their unit at Mount Sinai. So where they had sourced cases from all over Canada, transferred to Toronto. So the one issue they found was why the need arose in the US was because a lot of people, after knowing that the fetus has open neural tube defect and accepting it, did not want to terminate pregnancies, most likely because of religious reasons. So it was in those cases where the pregnancies, parents have opted to continue pregnancy in the first place, knowing that the fetus is going to have these kind of defects, then obviously rather than doing nothing, you would probably offer such a repair. What they found even in Canada, and what I personally think would probably even be here, is that if you probably in most cases where, let's say, the MTP Act is about to change, and if you can go to court with every such case of an open neural tube defect, if parents are given that sort of an option, that you go to court and you probably get to terminate, which is probably what we would have offered if it was before 20 weeks to begin with. I don't know what the uptake of such kind of intrauterine repairs are going to be in our population. I think it's going to be even more difficult than getting cases for a diaphragmatic hernia repair, than this, because the moment you say it's something neurological for our population, I think it becomes like if they have a choice, they never seem to take that sort of a.
If I have to say, it totally depends on how precious is the pregnancy.
Yes.
If the pregnancy is precious, they will do everything. So the general population may not do it. The younger population immediately after marriage, they may not opt for such a scenario. But somebody who is pregnant after 8-10 years or assisted production, then I think they may go for intrauterine repair. So being the population such a large of whatever 1.140 crore population, we have enough people who may be interested in fetoscopic surgery for whatever, not necessarily MMC, neural tube defect, but as of now, we don't have any center who is doing extensive fetoscopic surgery. They do some fetal intervention, but yes, in another 10 years, we will have enough center. And being a pediatric surgeon, being a laparoscopic surgeon, if we have to continue or transfer this knowledge into doing fetoscopic surgery, it is extension of what we are doing. It is, we don't have to acquire a lot of extra skill to do that. Of course, if we have pediatric neurosurgeon like Dr. Naresh Biani, Sumit Pawar, then we can do it together. Not only here, but I think all over India. There may be few centers which may come up over next 10 years.
Dr. Sumit, your thoughts on the matter?
There were few questions on chat box, but I think many of them are covered. One was the results of neural tube defect repair, which I think Dr. Biani covered. There were a couple of other questions which I put it on chat box. You can just ask them. But before you ask the questions, I will tell the audience that at SRCC Children's Hospital, after all this COVID lockdown, we are back to almost normal. We are at 80-90% of occupancy as well as surgical number wise. So, and those who have seen the hospital, they know there is social distancing anyway between the patients. And if you have any patients who needs any intervention, surgical intervention or other, you can consider SRCC Children's Hospital. Yeah, Shetal, you can continue, and Sumit can also say.
Sir, I am not seeing any questions on my
Chat box, I have written few, which I'll just tell you. Okay.
I'll read the questions. If there is a case that has increased AFP with a normal anomaly scan, should an MRI be indicated?
Dr. Pooja, do you want to take?
I think Dr.
I think I've already answered.
You had already answered this.
That,
That if
yeah.
there is no real other anomaly that is detected, then it's not really indicated.
However, uterine
some
artery
cases
Dopplers
it
with
would,
growth is required to see for placental dysfunction.
Sheetal, there was another question that they were asking about how do you do the counting of the levels. There was a slide that you had put up where Pooja had spoken about how to count from up and how to count from down.
Yes, I'll put it up again. There.
Yeah.
I mean, you can just say verbally also.
Basically, you can either count from down up,
ribs,
or you can count from up down. So the ribs, you see the level of the last rib that attaches to T12. So the next one after that is L1. So that is how you can count from up. And otherwise, the lowermost ossified vertebra that you see is usually the
S4.
Yeah, and then you count your way up from S4. That is how. So the highest most level, so the topmost level where the lesion begins is what we say is the first point. So it's not the lowest, but the highest point.
So I think the Sumit can give.
To answer your question, Dr. Sheetal, I'm very, very aggressive and looking forward to do a case of a fetoscopic repair because I'm a very active endoscopic spine surgeon. We have been able to do intradural detethering surgery with endoscope, and of course spinal cord tumor excision also with endoscope. So I think the expertise is increasing. And I also had met Dr. Lulla last year I had a case of 25-week-old who had an MMC, and I was very, very keen to do something for her. But of course, she was in the periphery, and they, like Dr. Rasisha said, they opted to go ahead termination of pregnancy. So we are still waiting for some case to come, and I'm very aggressive and waiting with my endoscope to see if we can do the repair.
Yes.
And closing remarks from Shetal.
So just to summarize, so basically at today's day and time, we can definitely rule out open neural tube defects at first trimester level. And by second trimester level, by the anomaly scan, all cases of neural tube defects can be identified. The one main point which matters as far as prognosis is concerned is whether the neural tube defect is open or closed. I think that's the one feature which decides how the outcome is. As far as interventions are concerned, I think in our country still periconceptual folic acid and B12 is probably the most important intervention as far as preventing neural tube defects are concerned. And we know that now closed neural tube defects, especially as how Dr. Biani said, that the spine is not really exposed to any other elements, has a good or a favorable outcome after a single detethering surgery. And this is a situation which definitely requires a multidisciplinary management like how we have on our panel today. So thank you for that very, very good discussion. And I had a great time moderating it. Thank you so much.
Thank you.
Thank you.
Thank you, everybody.
Thank you, everyone. Thanks a lot.
Thank you.
stop streaming, live streaming.
Thank you. Thank you, everyone.
Thank you.
Thank you. So we have ended the YouTube live session.